So today we will discuss about the second part of the opioid. So I think first part of the opioid is covered already. What are the different receptors for opioid? Where it is used commonly? What is the common use of opioids? Sedative. Anyone else? Analgesics. Very good. Which type of analgesics it is? There are primarily two types of analgesics. One is acts peripherally, skeletal muscle, bone fracture, and other one in visceral injuries. Example of visceral injuries are viscera, একটা viscera number of where there is a pain in that viscera. Myocardial infarction. In myocardial infarction, it is a visceral injury. Here the drug of choice for analgesia is opioid. Whereas in case of osteoarthritis, rheumatoid arthritis, which drug we prefer? Which group of drug as an analgesic? Louder. NSAID, non-steroidal anti-inflammatory drugs are preferred for osteoarthritis, rheumatoid arthritis, ankylosis spondylitis. Whereas in case of visceral pain like myocardial infarction, we preferred opioid analgesics. So opioid analgesics primarily act centrally or peripherally. Opioid analgesics acts primarily centrally, whereas NSAID they acts primarily peripherally. Next, which one we used in case of inflammatory condition? NSAID. In case of inflammatory conditions, examples of inflammatory condition like gout. We preferred non-steroidal anti-inflammatory analgesics over opioids. Clear? So opioid acts in which clinical situation? It acts centrally. It acts as a visceral in better in the visceral pain, and where there is a less inflammation. Or on the other hand, NSAID we used for analgesics acts as peripherally, musculoskeletal, and where there is a inflammation like gout. Clear? So among these opioid there are three receptors: mu, kappa, delta. Already described. The important thing is all the mu, kappa, delta has a analgesic activity, supraspinal and spinal, except kappa. In case of kappa, primarily K1 is the spinal and K3 is the supraspinal. Supraspinal means spinal cord, and supraspinal means spinal cord opore ki ache? Brain. It acts as in the brain. So both these three primarily both spinal as well as supraspinal action. Next one is there is a respiratory depression, all three. But in case of mu there is a euphoria, whereas there is a dysphoria in case of kappa. There is a psychomimetic action in case of kappa. So both these have analgesic action, respiratory depression action. So analgesic is a most common cause of use of opioids, and most common side effect is respiratory depression. Clear? Next, through the which endogenous opioid. Endogenous opioid means the opioid like substance which is synthesized inside the body in very small amount. They also acts in these receptors. And which one is the blocker of this receptor? Which drug to be used in case of morphine poisoning? Naloxone. Very good. Naloxone can block all action of morphine as well as endogenous opioids. Naloxone can block action of endogenous opioid. The primary three endogenous opioids are endorphin, enkephalin and dynorphin. Endorphin, so you have to remember these three term name: endorphin, enkephalin and dynorphin. Other than opioids, there are three other class pure antagonists. Pure antagonists are naloxone, naltrexone and nalmefene. These are the pure opioid antagonists. What is antagonist? What is the antagonist? So there is a affinity, but intrinsic activity is 0. Very good. So naloxone, naltrexone, nalmefene is pure antagonist. Now there is another term, agonist antagonist, specially called as a kappa analgesics, where there is a agonistic activity in the kappa, but there is a antagonistic activity in the delta and mu. Pentazocine butorphanol is the name of this agonist antagonist. So what is agonist antagonist? They act agonist in the kappa receptor and antagonistic activity in the other opioid receptors. Clear? So agonistic activity means intrinsic activity, affinity, koto affinity +1. Affinity +1. For other receptors, means other opioid receptors, their affinity is 0 or intrinsic activity is 0. So affinity is there, but intrinsic activity is 0. And third one is partial or weak mu agonist plus kappa antagonist. Buprenorphine is the example of that. Buprenorphine. That means for buprenorphine, intrinsic activity in mu is mu. Buprenorphine is a partial or weak agonist, 0 to +1, in between 0 to +1 intrinsic activity. For kappa antagonist, then that means 0. Very good. So where there will be -1 intrinsic activity, example, where in which receptor? Benzoate. Very good. So there are agonist, antagonist, partial agonist, inverse agonist, and there is another term, agonist antagonist. For same group of receptors. So for kappa it is agonist, and for other receptor it is antagonist. For mu it is partial agonist, whereas for kappa it is antagonist. Clear? So other than proper morphine, pethidine, there is other classification where there is a agonist antagonist, partial mu agonist with kappa antagonist and pure antagonist. So in mu receptor, I think already it is discussed what are the main action. Main action, you have to remember analgesia. Which type of analgesia? Centrally acting analgesia. It acts in a visceral pain better than NSAID in case of non-inflammatory condition. Along with that, it produces euphoria for the mu receptor. It causes respiratory depression as a side effect. Respiratory depression, nausea, vomiting, decreased gastrointestinal motility, and it can produce tolerance and dependence. In case of myocardial infarction, CVS complete. In myocardial infarction, the analgesia of choice is aspirin. In which dose aspirin given in this situation? and in low dose aspirin acts as a antiplatelet. So in case of myocardial infarction, though aspirin as well as morphine can be given, for analgesic purpose we give morphine. Clear? And even before the giving morphine, we give another drug. No, not before that. Before giving morphine, there is a ondansetron to prevent vomiting. Clear? So which is a side effect of morphine. Clear? Similarly, in case of myocardial infarction, we give aspirin in which dose? Dose is, first there is a loading dose 325, then maintenance 75 to 150, and it acts as a antiplatelet, not as a analgesic dose. Clear? So for mu receptor, analgesia, euphoria, respiratory depression, nausea, vomiting. So for any time you have to remember, you have to give a antiemetic before giving morphine in case of myocardial infarction. Similarly, another explain why we preferred morphine. Not only morphine reduce the pain, which is visceral pain, and reduce anxiety also. It also reduce as it acts spinal and supraspinal, they also reduce anxiety, and that is also helpful for myocardial infarction. Why? If there is a decreased anxiety, what happens? Next one is heart rate will be reduced. If heart rate will be reduced, oxygen demand will be reduced. That also helpful for reducing the pain. So why opioid is preferred over aspirin or NSAID as an analgesic? It is also should be covered in case of myocardial infarction, but you have to remember 2 points. One is, number one, it is a visceral pain, it is a non-inflammatory pain, and as it is a spinal and supraspinal, analgesia is preferred in this. Second point is that it reduces anxiety. As it produces some euphoric state, it reduces anxiety. By reduce anxiety, what happens? Heart rate will be reduced. As heart rate will be reduced, oxygen demand will be reduced. So this pain of myocardial infarction is due to demand supply of oxygen is reduced. So it helps to relieve the pain also by reducing oxygen demand. 2 points you have to remember. Why morphine used in myocardial infarction as an analgesic over NSAID, but aspirin not as a analgesic in case of myocardial infarction. Taito? As a antiplatelet. Clear? Ki holo eta ba? Dysphoric state produced by the ki holo eta? Kato? Kappa receptor and delta receptor, they causes behavioral changes, and they can also produce some dysphoric changes, where mu causes euphoria. Other receptors like kappa causes dysphoric state, and delta produce a pro-convulsant state. Pro-convulsant means convulsion tar pro, মানে it can produce or reduce the threshold of convulsion. Delta. Clear? So analgesia, spinal and supraspinal for both mu, kappa, delta. Respiratory depression for mu, kappa, delta. Then euphoria for mu, dysphoria and psychomimetic behavior for kappa, and case of effective behavior and pro-convulsion for the delta. Clear? এগুলো দরকার নেই. Morphine acts mu, kappa as well as delta activation. Whereas fentanyl and sufentanil, where you have heard this name, fentanyl and sufentanil commonly used as a anti-cancer. Okay, analgesic. Anti-cancer পড়ানো হয়েছে? ড্রাগসের প্যাচের ওখানে ছিল, ভেরি গুড। তাহলে আর কোন ড্রাগ প্যাচে দেওয়া যায় ট্রান্সডার্মাল প্যাচে? আদা হায়োসিন, ভেরি গুড। কোথায় ইউজ হয়? মর্নিং সিকনেসে কি ড্রাগ ইউজ হয়? স্কোপোলামিন কিসে ইউজ হয় মর্নিং সিকনেসে? মর্নিং সিকনেস, নট মোশন সিকনেস। তিনটে সিকনেস মনে রাখতে হবে, মোশন সিকনেস, মর্নিং সিকনেস এন্ড মাউন্টেন সিকনেস। মাউন্টেন সিকনেসে কি ইউজ হয়? অ্যাসিটাজোলামাইন, ভেরি গুড। তাহলে বাকি রইল কি মর্নিং সিকনেসে কি কি ইউজ হয়? হ্যাঁ, থ্যালিডোমাইড তো ব্যান হয়ে গেছে। থ্যালিডোমাইড, why it is important? Thalidomide, it causes phocomelia. It is a teratogenic drug. তাহলে এটা হোমওয়ার্ক, which drug is drug of choice for morning sickness? ঠিক আছে। whereas fentanyl primarily used for কোথায় কোথায়? ডক্সিলামাইন, ভেরি গুড। কোথায় কোথায় ইউজ হয় ফেন্টানিল? একটা ক্যান্সার পেশেন্টে অ্যাজ এ অ্যানালজেসিক ট্রান্সডার্মাল প্যাচ, রেয়ার ইউজ। মোর কমন ইউজ আর অ্যাজ এ intravenous general anesthetics. Intravenous general anesthetics. Name other intravenous general anesthetics. এটা তো ছিল পরীক্ষায়। Other than fentanyl, is there any intravenous general anesthetics? Ketamine, very good. দেখে দেখে বলছো নাকি? প্রোপোফল, কিটামিন। কিটামিনে কি স্পেসিফিক? ব্লাড প্রেসার, আইওপি, ইন্ট্রাক্রেনিয়াল টেনশন সব কটা বাড়ায় না কমায়? ইনক্রিজ করে। বা মোস্ট অফ দেম বিপি কমায়, বাট কিটামিন দে ইনক্রিজ hypertension, increase IOP, increase ICT. So fentanyl, when used as a general anesthetics or as a patch, it primarily acts through the receptor. Receptor name is mu. The difference is, for morphine, mu, delta, kappa, all three receptors used for its analgesic effect, whereas morphine primarily acts through mu receptor. But as a potency, as an analgesic potency, fentanyl is much more potent than morphine, as well as their side effects are lesser than the morphine. Clear? MCQ, in which receptor fentanyl acts? Mu kappa delta. None of the above. Mu hobe kintu, huh? Next, endogenous opioid. It is a peptide which secretes from the body in very small amount. In which portion? কোথা থেকে হতে পারে? CNS primarily. CNS বলতে গেলে কি কি বলতে হবে? Brain, spinal cord, pituitary. Other than CNS, GIT. So 4 source of release of endogenous opioid. Very small. Their action also blocked by naloxone. Naloxone is pure opioid antagonist. Binds high affinity with the opioid receptors. There are 3 distinct peptide families are there. Their primary action is modulate the pain. So what are the 3 family? First one is beta endorphin. Beta endorphin, it most important, it secretes from the pro-opiomelanocorticotropin. From this, other than this beta endorphin, there is MSH. What is MSH? ACTH and 2-lipoprotein also synthesized from this. So where it acts, the receptors are important. Mu is most important for beta endorphin, followed by delta, and it has a lesser action in the kappa. The primarily mu followed by delta and very less action on the kappa. Clear? It is 20 to 40 times more potent as an analgesic in compared to the morphine. Here another important thing, their T half is longer, so it is called acts as a neurohormone. Neurohormone. If it is small, then it is called neurotransmitter. Time T-half of endorphin is longer, so it is called it acts as a hormone type. That if T-half is high, it is so it is called neurohormonal. They decrease LH FSH release, whereas increase prolactin and growth hormone. Release has been increased of prolactin and growth hormone by this endorphin, whereas they reduce LH FSH. Primary action is that of this endorphin is modulation of pain. It is more potent than morphine. In which receptor they act? Mu, kappa is least. Then enkephalin. There are two types of enkephalin, methionine and leucine enkephalin. Where they act primarily in delta. Most importantly, delta followed by equals to mu and very less in the kappa. So, for both enkephalin and endorphin, least important is kappa, and for endorphin it most important is mu, and for enkephalin it is comparable, mu and delta. Delta if somewhat more important than mu, but for both these two, kappa is least important. Dynorphin, which receptor? Kappa is the major receptor, followed by very less action in mu as well as delta. Clear? And here their T-half is very less, so it also called neuromodulator or neurotransmitter type of action. If it for endorphin, T-half is endorphin এর জন্য T-half is more, so it is acts as a neurohormone, whereas dynorphin there is a T-half is less, so it acts as a neurotransmitter or neuromodulator. Clear? কোন রিসেপ্টরে কাজ করে? রিসেপ্টর গুলো কিন্তু এমসিকিউ তে আসতে পারে। ডাইনরফিনের জন্য কাপ্পা আর বাকি দুটোর জন্য কাপ্পা লিস্ট, মিউ হচ্ছে ফার্স্ট এরটা, তার মানে বিটা এন্ডরফিনের জন্য ডেল্টা মিউ more or less, delta sometimes more important for enkephalin. For dynorphin, the most important receptor is kappa receptor. So beta endorphin mu, enkephalin mu and delta, dynorphin kappa, endomorphin. Nowadays another one is endomorphin, they also acts on a mu receptor. Nociceptive, another specific receptor, NOP receptor, nociceptive. It also, these two are newer endogenous opioids. Clear? Receptor কিন্তু একটা এমসিকিউ আসতে পারে কিন্তু, হ্যাঁ। Next, acute morphine poisoning. Acute morphine poisoning. For acute morphine poisoning, the dose is more than 50 milligram, but lethal dose is 250 milligram. Clear? For toxicity, if more than 50, they can cause toxicity. Lethal dose means if it is given in 100 people, 50 people will be die. So lethal dose is 250. Now what are the symptoms? What are the symptoms of this toxicity of morphine? Number one, stupor, shallow breathing, cyanosis, pinpoint pupil, fall of BP, then convulsion and coma. তাহলে রেসপিরেটরি ডিপ্রেশন হবে, রেসপিরেটরি ডিপ্রেশন হলে কি হবে? স্টুপর হবে, তারপরে কি হবে? কনভালশন হবে, কোমায় যাবে। The important thing is cyanosis, they can produce cyanosis and pinpoint pupil. Now you tell me what are other toxicity or so how you can differentiate between OP poisoning with morphine poisoning? ওখানে কি হবে? hot flush skin for atropine poisoning. So here there is a shallow breathing. There will be more salivation. Secretion will be much more. Clear? Here there is a pinpoint pupil. Now next important thing is that what are the drugs used or toxicity for toxicity of OP poisoning? Atropine, very good. For this, naloxone. Clear? So you have to give this drug to see that first one is that symptom, other than symptom there is a history. History will be কি থাকবে for OP poisoning? Acidity থাকবে না, হিস্ট্রি কি থাকবে, কোথায় কাজ করছে পেশেন্টটা, কোথায়, ফার্মার ইনসেকটিসাইডস দিচ্ছিল বা ইনসেকটিসাইড খেয়ে নিয়েছে, এটাই থাকবে। Here there is a specific that either there is a analgesic, কারণ morphine is not that easy available. Morphine is not that easy available. So either he or she or her family have a cancer patient or something like that where there is a available of this morphine. Clear? The more clinically both can has a pinpoint pupil meiosis, but there will be much more frothy secretion through the trachea, and there will be lacrimation, urination, defecation. Here the patient will be dry, but there will be shallow breathing, and that can cause cyanosis also. Here the drug of choice is naloxone. In which route? Intravenous route. Before that, which are important? IV fluid and electrolyte balance, and much more important that is respiratory security. That means there is a কি করবে যদি রেসপিরেটরি ডিপ্রেশন হয়, আর্টিফিশিয়াল মেকানিক্যাল ভেন্টিলেশন, ঠিক আছে, ইনটিউবেশন এন্ড পজিটিভ প্রেসার ভেন্টিলেশন, if possible gastric lavage, and naloxone is the specific antidote. Clear? Toxic dose is 50 milligram, lethal dose is 250 milligram. Drug of choice is naloxone. There will be respiratory depression, stupor, then there is be convulsion, coma, and there is a pinpoint pupil and cyanosis. Clear? In university examination, if there is a clinical feature, they also mention that which type of poisoning is there. Then only then there will be the next questions. But for MCQs, for NEET, they will not give that clue. Clear? So for that purpose, you have to remember how to differentiate different poisoning from the clinical feature or history. They will not mention that it is organophosphorus poisoning or morphine poisoning. But for university examination, they will mention that it is organophosphorus poisoning. Now you tell me what are the treatment of choice, which drug to be given, how it acts. But for MCQ purpose, they will not mention which type of toxicity is there. Next is tolerance and dependence. What is tolerance? Tolerance means after repeated use of a same drug, in this case morphine or opioid drugs, to achieve same type of analgesic in this case, but any pharmacological action, we require much more drug. Clear? So after repeated use, to achieve the same pharmacological effect, if the drug required higher amount, then it is called, there is a production of this tolerance. Example is morphine. Other example already discussed in which topic? Tolerance in জেনারেল ফার্মাকোলজি। জেনারেল সব থাকে, তারপরে অন্য সিস্টেমে ইউ হার্ড দ্য নেম ট্যাকফাইল্যাক্সিস। ট্যাকিফাইল্যাক্সিস কোন ড্রাগের হয়? এফিড্রিন। এফিড্রিন কিভাবে কাজ করে? What is the difference between tolerance and tactile axis? That same thing, tolerance and tactile axis is same thing, but tactile axis, for tactile axis it is much earlier. Tolerance develop very rapidly, that is tactile axis. It is occurred in the ephedrine, where there is they act in a receptor or they release adrenaline, noradrenaline for that. So indirect sympathomimetic have this property of tactile axis, indirect or mixed type of, whereas that is tactile is a tolerance which develops very early. Example is ephedrine. Whereas for this morphine, what is tolerance then? Tolerance is requirement of higher amount of drug to achieve the same therapeutic level after repeated use. Clear? Then what is dependence? Dependence is the some physical and psychological symptoms that will happen in absence of this drug. Clear? দুটো পার্থক্য করতে পারছো? Tolerance means that it is the effect will reduce, pharmacological effect will reduce, and to achieve that level it requires higher amount. And physical or mental dependence means in absence of the drug there are production of some symptoms, then it is called physical dependence, characterized by withdrawal or abstinence syndromes. Clear? What is tolerance? What is dependence? So how this dependence and tolerance occur? It is required to reactivate by endocytosis and recycling. Receptor the recycling, it is, if it is absent, then there is a production of tolerance and physical dependence. Morphine fails to induce the endocytosis, but methadone can produce. So methadone can use to reverse the dependence and tolerance of morphine. Clear? So which drug is used to rehabilitate from the morphine addiction is methadone. In which receptor they act? They also act in the opioid receptor, but they doesn't have the high, the peak action. There is a maintenance action and they can induce endocytosis of the receptor. So they prevent dependence and tolerance of morphine or morphine আর কি গ্রুপে সাবস্টেন্স আছে? হেরোইন কোন গ্রুপের ড্রাগ? সেমি সিনথেটিক, সিনথেটিক পড়ানো হয়েছিল ক্লাসিফিকেশনে? In case of heroin addict also, this methadone can be used. NMDA receptor channel complex antagonist like ketamine can also produce tolerance development. Clear? So withdrawal symptoms ki hobe? Agitation, hyperalgesia, hyperthermia, there will be diarrhea, pupillary dilatation, release of all pituitary and adrenomedullary hormones, they will be affected, and symptoms like dysphoria, anxiety, depression. These are the all withdrawal symptoms. Where are the contraindications? Contraindication of use of tolerance and dependence ta motamuti বোঝা গেছে তো? And which drug to be used? কোন drug? Methadone. ঠিক আছে? Now there are many explain why from this morphine. So why it is not used both pure agonist with weak or partial agonist? In presence of pure agonist, weak or partial agonist can produce withdrawal symptoms by acting as an antagonist. বুঝতে পেরেছো? So morphine with pentazocine, it reduces analgesia or even induced a state of withdrawal. Pentazocine is a partial agonist. It should not be used along with morphine for analgesia. Similarly, why it should not be used in a head injury? কোথায় কোথায় use করবে না? Undiagnosed abdominal pain, you cannot be used morphine as a first analgesic. Secondly, you cannot be used as an analgesic in case of head injury. Why? Why we should not use morphine as a, it is a head is, brain is a visceral injury, even then we cannot use as a first line drug because it produce cerebral dilatation that increase CO2. They reduce respiratory depression, produce respiratory depression, and for the head injury, by if there is a hemorrhage and there is a respiratory hemorrhage in the respiratory center or pressure in the respiratory center, that can also produce respiratory depression. So they augment this respiratory depression. Third one is it produce vomiting, meiosis. All these are very similar symptoms when there is an increased ICT. Intracranial tension, if it is high, the symptoms are vomiting, altered mentation and meiosis. So diagnosis of this head injury will be difficult. So why we should not use morphine in head injury? Number one, they produce vasodilatation, they increase intracranial pressure, they also reduce the respiratory center, depress the respiratory center, and for the meiosis is due to the morphine or meiosis due to the pontine hemorrhage. If there is a hemorrhage in the pontine, they also called meiosis. There can be, if there is a hemorrhage, there is a ICT will be raised, intracranial pressure. That can produce vomiting, that can produce altermentation. Similar symptoms with the increased ICT hemorrhage like the morphine pharmacological action. So it is very difficult to differentiate between these symptoms is due to the increased intracranial pressure or due to the morphine. So for this purpose, we are not advised to use morphine as a first line analgesic in case of head injury. কি হলো ফার্স্টে? ইনক্রিজ ভেসোডাইলেটেশন, কার্বন ডাইঅক্সাইড রিটেনশন বাড়াবে যার ফলে আইসিটি বাড়বে, that will increase ICT. Number 3 is respiratory depression, and the symptoms are increased ICT, that is vomiting, altermentation and pupillary constriction is similar to the action of the morphine. So it is very difficult to differentiate. It is due to the morphine or it is due to the increased ICT. In case of undiagnosed abdominal pain, they can produce sphincter constriction. If there is a gallstone, there will be increased pain. Biliary colica, it is contraindicated. Example, explain why. Why it is not used in undiagnosed abdominal pain, why it is not used in head injury. Similarly, in case of pregnancy, it cross the placental barrier, go into the fetus, and it produce tolerance and dependence and withdrawal symptom for this fetus. So it is not used. If it is used and there is a withdrawal symptom for the fetus, the first diazepam in case of mild withdrawal followed by methadone for the fetus. Next is pulmonary function. So pulmonary function defect means if there is a asthma or COPD, already impaired lung function, there is respiratory depression. So there is a exaggeration of this pulmonary impairment. Hepatic and renal failure. If there is a hepatic or renal failure, what happen? This morphine and its metabolites will be much more time inside the body. So toxicity will be developed. In case of endocrine disease, adrenal insufficiency, namely Addison's disease and myxedema, they exaggerated their response of opioids. So these are the contraindications of opioids. Clear? Konta agonist antagonist, partial antagonist, agonist আর হচ্ছে pure antagonist. Mu, kappa, delta, which are the endogenous opioids acts. What are the different contraindications of use of morphine?